Hello, and welcome to another evening of Detox Me Now. Sorry, I had a little glitch in the scheduling. My producer scheduled us at 7, and we're supposed to go on at 7:45, and I had to deal with some patients in the hospital. But as most of you recall from my last show, I want to talk about the food classification system tonight. And it's quite a long presentation because what I want to do is go through the food classification system with you and talk about how we manipulate nutrition in a special way. Most of us know that eating healthy is important, eating a healthy diet. And many of my patients come and say, hey, doc, I eat healthy. My diet is clean. I'm a vegetarian, or I'm a vegan, or whatever the case is. I'm whole food, plant-based, or whatever. I'm a keto, etc. But what do these labels mean, and how precise are they? What are you exactly putting in your mouth, and what are the characteristics of the food? And I think these things are very important questions to answer, because there's a lot of confusion about eating healthy, and I see lots of patients who come to see us, and they're eating a quote unquote healthy diet, but they still have high blood pressure, their cholesterol is still off, and these types of things. So I really want us to delve into this whole concept of healthy food. And the best way to deal with it is to be precise. So what we're going to deal with tonight is the food classification system. And I'm going to talk to you about our clinical application. So sit back, get your pen and paper out, and stay tuned, because this is going to be a very enlightening show. And we're going to share quite a few concepts with you. Let's get started. Okay, so let's get started. We have a long show tonight. So, what is the food classification system? We have a proprietary system of classifying foods, and it goes into not only what the food is, but how the food's prepared and the like. And so I want to get into the concepts, and we're going to talk about how we use it in a clinical setting. But generally speaking, this represents a new standard in which how we evaluate patients. And so if you come to the Montgomery Heart and Wellness Center, many of you may have been to our center, we have a comprehensive way of evaluating our patients. And I'm just going to go through some of these general things to put the food classification system and the food prescription system into some level of context. So generally, we do a clinical evaluation. So all of our patients get a history and physical examination. I assess the patient, or my physician assistant assess the patient. But in addition to the standard history and physical, we get a nutritional history. We also try to assess your activity level. And then we start to get tests. We get biochemical assessments. We get lots of blood work. We may collect urine. We check micronutrient tests. We get physiological assessment. We check Doppler studies and carotid vascular studies. And so we then try to get you assigned to some kind of a clinical standard. And this is somewhat of a loose application here. So, for instance, we have patients who come into our office who are in severe heart failure, their heart rate's out of control, and they may need to go to the emergency room, that day. We may have other individuals who come and they have no known clinical problems. They're just here for a checkup, but they have some family risk and other problems, and they for that evaluation. So we assess our patients, and we put them in a category in terms of the level of criticalness and level of illness. Some patients we have to give intravenous diuretics on the spot, or intravenous fluid. So we make this broad clinical evaluation, and then we start a therapeutic intervention. And so that's how we get started. So what do we do with medications? We often have patients who come in who are on a large list of medications. It's nothing to see a patient on a list of 20 medications or 15. So frequently, that's the first thing we have to deal with many of our patients. So we have to consider the possible need for changing medication, et cetera. Many of our patients have, advanced heart disease or other advanced illnesses. So we help evaluate them for surgery. Some come for surgical clearance. So we're often evaluating all of those things. And then we look at the overall health condition and say, okay, what do we need to do on the natural approach to either delay surgery? For instance, if someone's coming to get clearance to have back surgery, for example, they may have a lot of active disease. Maybe they have heart failure. Maybe they have inflammatory conditions. We may have to put them on a nutritional intervention or detox to get them ready for the surgery. So we make all of these clinical evaluations, and it's all integrated within the approach that we take. And so I'm giving you all of this information to say, this food prescription approach that we use is part and parcel to a whole scope of things that we're doing for our patients. So if I'm writing a pharmacological prescription, or I may be writing a prescription for a nutraceutical, a specific type of vitamin, a mineral, or intravenous nutrient, all of these things are being designed and developed in the context of the patient, as well as the food prescription. So the food prescription is in the context of a whole gamut of things that we're doing for the patient. For instance, I have patients in the hospital, even at the time of this recording, I have patients in the hospital who are on a food prescription approach, getting nutraceuticals, as well as getting Western medical therapy. So it's an integrative approach. So what is this nutritional integration? Hello, Black and Silver, Shonda's Real Food and Drinks. Welcome. Sorry, I hope I got a late start with you guys. We did a little shake and bake from 7 to 7:45, but welcome. Jackie Girl 19 Phillips, hello, and D Park 1240, hello, and Sonia Anderson, good evening. Welcome. Get your questions ready as we go through this whole approach. So let's get into the nuts and bolts of the food classification system. So first of all, the food classification system is based on fundamental characteristics of food. And the fundamental characteristic we like to look at is, one, processing. How is the food processed? We want minimal processing of the food. Have we added chemical preservatives to it? Has it been irradiated? Has it been fried? Has it been, what has been done to the food? Has it been spat on and stomped on? If we do a lot of stuff to the food before we consume it, it can actually change the characteristics of the food. So a food that is inherently healthy can become unhealthy if it's overly processed or processed in the wrong way. We want the whole foods. What do I mean by that? We want extracts. One common food extract that we try to have our patients avoid are foods that are oils. Like if you extract the oils from the olive, it's a very unhealthy food substance. So we want whole foods as much as possible. And of course, plant-based. The data is very strong that plant-based foods are optimal for our body, and they're essential to any healthy diet. So minimally processed whole plant foods are the characteristics we look at. The more of these characteristics they feel, the better the classification value they get. And we're going to go into that numbering system that we use in our classification system. Hello, Catherine Welch. So it's important that we don't use labels. Labels are frequently used: vegetarian, vegan, raw vegan, keto, paleo. All these labels are not very precise. Even though I recommend a plant-based diet, it's possible to have someone on a plant-based diet that's less healthy than someone that's on a keto diet. Now, people in the plant-based community say, hey, how is it? What are you talking about, Dr. Montgomery? Sure, if you eat all plant-based junk, and someone on a keto diet may be eating a small amount of animal protein, they may not be eating all the fats and bacon that often the keto diet recommends, but they're eating lots of greens and so on, and they're just eating very low carbohydrates. They may be filling the quote unquote keto recommendations in general, meaning low carbohydrates, but they're not eating as much junk in general. So the labels are not very precise. And so we have to get beyond just the labels and get into something more specific. And that's what the classification system is about. So we try to assess the global aspects of food. We don't limit to calories and sugars and fat content, et cetera. These things are important in general, but it's very superficial. So what characteristics? Well, as I said before, plant versus animal, inorganic versus organic, synthetic. What are the conditions of development? If you have potatoes, for instance, that's grown in, that's conventionally grown, and maybe it's grown in a field where there's toxic chemicals in the soil, so it's not organically grown. Well, those potatoes may soak up a lot of the toxic chemicals in the soil because the potatoes are root vegetables. So if you grow your plants in a condition that's not very healthy, then you're going to have food that's not very healthy. So what are the conditions of development? Wild over organic and organic over conventional. Those are things that we look at. Level of processing, as I alluded to before. Has it been fried or microwaved, or has it had lots of chemical preservatives that added to it? These are the things that we look at, that we base our food classification system on. And of course, basic chemical characteristics. Is it a very hydrating food, or is it a dehydrated food, and so on and so forth. And the potential effects on the human body, that goes hand in hand with some of the other characteristics, such as whether it's hydrating, etc. Yolanda wants to know, ate gumbo, post-family funeral, how to live successfully plant-based among carnivores. Okay. Sometimes you have to just avoid eating what the carnivores eat. So what is this classification system? So I gave you the nuts and bolts in terms of the foundation, the concepts of what defines a classification system. So what is the actual system itself? It's a system of assigning foods and other nutritional substances to categories based on their ability to facilitate optimal biochemical physiological condition. Essentially, what we have is a 0 to 10 numbering system. The lower the number, the healthier the food. The higher the number, the least healthy. From 0 to 6 are all plant-based foods. 0 are raw juiced foods. So it may be smoothies or cold pressed juices or water. These are the more hydrating components of foods. And I'll get into why 0 is higher than, say, raw solids. From 1 to 3 are raw solid foods. As 1 is low glycemic index, raw solids. 3, high glycemic index. Level 2 is in the middle. 4 is a transition zone. 4A are raw foods that are high fat content. In other words, they're greater than 20% fat per caloric content of the food. 4B is a dehydrated food, not necessarily high content. So an example of a 4A will be a raw seed or a raw nut or an avocado that's raw. 4B would be a food that's dehydrated, not heated above 160 degrees, usually heated between room temperature and 120 degrees. So it's dehydrated, but low temperature heated. And then 4C would be blanched food. So it's heated above 160, above 200, but on a very short period of time. So you may get frozen foods that are blanched or things that are flash steamed. 5 is boiled or steamed at a shorter duration at high temperatures. And 6 is boiled and steamed at high temperatures. And they also can be dry heated at 5 and 6 as well. So you have plant foods that are processed to different degrees. The higher up you get, the more it's processed in terms of dehydration at 4B and heated extensively at 5 and 6. So those are your cooked plant foods. Now, beyond 6, 7, 8, 9 is when you get into animal protein, and it's more processed and animal proteins on up. So I'm not going to get into those in detail because we prescribe foods from levels 0 to 6. But we give you levels 10 to give context in terms of where people are. So that 0 to 10 classification scheme is how we assign foods. And so when you see some of the food classification recommendations down below, you'll understand where they are. And I'll kind of reiterate the levels of healthiness. Sonia Anderson, is it okay to consume avocados? Well, Sonia, type in the screen if you remember, what food level would avocados be, or anybody, what food level would avocados be based on what I said? So let me see who is listening. We got about, a handful of people online. What food avocados? So what level would avocados be? Would it be 0, 1, 2, 3? Would it be 4A, 4B, or 4C? Let me see who's listening. Or would it be 5 or 6? What level is avocado? So the fundamental source, origin of the plant, animal, So that's a characteristic of the food, as we said, the conditions of development, as I said before, level of processing, and basic characteristics. Okay, Deepak 1240 said 4, Sonia said 4. And let's see, Sonia Real Foods and Drink says 4B, cannot recall. Y'all are close. What about 4A? Samitra Thomas, I think 4A for raw plant foods with fat content. Yes, Sonia wins. It's 4A would be an avocado. And yes, you can consume avocados on detox. That's a great question, by the way. And potential effects on the human body. So overview, the food classification system. The essence of the food RX system, it provides structured nutritional plan. So when I'm prescribing foods, I have a lot of patients who are very sick. Some of the patients have to be on just level 0 for a prolonged period of time. Then I move from 0 to 3. Then I move from 0 to 4A, then back down to 0. So we use this food prescription approach for patients at various needs. The heart failure patients, they may be on 0 to 4A only. And then some people 0 to 4B, some people 0 to 6. So we use this program in the numbering system, and it goes beyond calorie counting and portion measuring. We allow our patients to eat what's called ad libitum, meaning that they can eat freely, but we can measure their compliance not based on the quantity of the food they're eating. We measure compliance based on the quality of the food they're eating, which is very important. And what we found in the number of congrats on, we found in the number of years that we've done nutritional detox programs in the form of our boot camp classes and the like, we found that when our clients eat a high quality food, they naturally control their portion size. In fact, in our study, I'm going to show you some of the data later on in this discussion, is that the calorie count on these patients was reduced when we were able to put them on the detox meal plan. They naturally ate less because they were getting a higher quality of food. And so it enabled them to eat less naturally. It enables for therapeutic precision, so we can quantify people's compliance. So let's get into a few program specifics. And I want to, it's no better way to share how we apply this than to get into some clinical examples. So I'll share a couple of patients. There's a 59-year-old man who we saw a number of years ago. He came in as a new patient, had symptoms of fatigue. And interestingly, he had some eye pain and some headaches. He also had, did not have symptoms of chest discomfort, shortness of breath, or palpitations, but his blood pressure was 136/81. However, his main reason for coming in, interestingly enough, it wasn't the high cholesterol. I mean, even though his total cholesterol is 317, LDL 227, HDL 70, triglycerides 286. But for the first time, he saw his hemoglobin A1C was 6.3, and he was threatening to become a diabetic, and that sort of got him a little nervous. So that hemoglobin A1C of 6.3, although that cholesterol 317 is pretty bad enough. He had a little bit of inflammation. The CRP is a little bit high at 1.4, or like at less than 1. So he had a recent diagnosis of quote unquote type 2 diabetes or prediabetes. The elevated cholesterol he had known for years. And of course, he had a history of hypertension, and he was on some treatment for that, diet and lifestyle treatment. So anyway, so what did he eat? He ate fruits and vegetables. He ate fish and chicken, dairy and eggs. He exercised 2 to 3 times per week. He took Excedrin for the eye pain. And so we put him at clinical category 3. Now, that's not so important for this discussion. But the point I want to point out is this. You know, this in many people's mind is a healthy diet. So if you go and see your doc, say, well, doc, I eat healthy. You know, I eat lots of fruits and vegetables. Other patients, I eat lots of fruits and vegetables. And we may not mention what and oftentimes the patient, I said, well, what do you eat? They said, well, I eat salad and I have oatmeal for breakfast and blah, blah, blah. And so I say, I eat healthy, but they may not mention the fish. And so, well, what do you like to eat? Well, you know, I may go to Papados or so and so. Oh, what do you like to eat there? And then they get into some of their favorite foods. And I may get into the shrimp and the fried this, that, and the other. So we try to get into the details because it's important, because if you're consuming, they may not be eating fish and chicken every day. They may have 3 days a week where they eat only plant foods, but a small amount of these things on a regular basis can keep the cholesterol up or whatever the case is. So we try to get into some of the details. So if we look at the treatment option, so what would we do? This cholesterol level is very high. Should we put them on a statin, ACE inhibitor for blood pressure meds? Should we give them metformin? Is the hemoglobin 6.3? So that's A. How about medical therapy and complex lifestyle? We can put them on the medications above and have them exercise more. He's exercised 2 to 3 times a week, exercise 5 times a week, 7 times a week, 14 times a week, do meditation. Or could we just give them the food prescription alone? Put them on a detox regimen with clinical monitoring and baseline 1-month follow. So what would y'all choose? Go into the chat line. Who would choose A? Who would choose B? Who would choose C? Anybody? I'll give you a few minutes. So what do y'all want to do? Catherine Welch, you're going to go with option A, B, or C. Sumitra, nobody wants to respond. I'll give you the answer. Drum roll. Well, we chose C. We chose starting with a nutritional regimen alone. A lot of my colleagues would start them off with medications. Does have a history of hypertension, hemoglobin A1C. Part of the standard is to start them on metformin. A lot of you choosing C. I agree with that. But we put them on a food prescription. We start them off at food level 0 to 4B. Now, who on 0 to 4B, give me a yes or no. Can you have avocados in the prescription we gave them? Yes or no? And while I'll wait for y'all to answer, he said, do not consume a bite, drop, or crumb, or anything outside of food B. Can't see the screen. Okay, oops. Is that better, Sonia? I'm taking me out. Great. So yes, you can have it. Yes, Depark 1240. The answer is yes. You can have avocados in 0 to 4B because avocados are 4A. We continue the current medication for eye pain. We obtain baseline cardiac studies and biomarkers. So we do all of our standard testing. And so here's a diagram showing the food classification system. We give this as a handout. And I know it's a little bit complex here, but if you want to take a photograph of that and you can look closely, but he was eating 0 to 4B. And so that gets him right in this little category here. I'll make my little cursor move a little faster there. And he could have dehydrated foods. And the important part of that with the dehydrated foods is that, we can do some things. We can create breads. We can create a number of things that enhances the texture of foods and it enhances the compliance. So if you do 0 to 3, which is our traditional detox regimen, it's good, but it takes away 4A, so you wouldn't be able to have avocados. You can have your salads. We wouldn't have avocados. And some people are in 0 to 3. We have to be more aggressive with some people, more so than others. So that's going to be the case there. So here's a compliance card. So we can measure if they eat level 0. So let's say, for instance, in a 7-day week, they ate level 0 on, let's say 4 of the days or 5 of the days, and level 0 to 3 another 2 days. Then we can calculate the percentage of the time they ate level 0 and the time they ate level 0 to 3. So week 1, he was 100% from 0 to 3. Week 2, he was 100% from 0 to 3. And week 3, it was 100%. He was 86% 0 to 3. But guess what? He had 1 day that he ate level 7. I think he had some tuna fish or something like that. And if you notice in my notes here, he had increased energy after the initial week. After 10 days, his eye pain subsided. So within week 2, week 1, week 2, that's 14 days at the end of week 2. So before the end of week 2, his eye pain went away just on the food alone. But in week 3, he had 1 day that he was outside of 0 to 3, outside of 0 to 4B rather. And his eye pain recurred after he ate level 7 on 4/16. So that was within the 3rd week. So notice how he had more symptoms on just going outside of the detox room. He got back on the program on the week 4, and pain subsided again after resuming the plan. So it shows the precision in terms of how well it does. And we'll look at some of the data. The blood pressure, day one, This is the blood pressure, and it goes down after the first week. After the third week, it goes up, comes back down, and stays down. So overall, it goes from 136 systolic to 121 systolic. The diastolic goes from 81 to 71, but notice it bumps and then comes down. And the weights come down. It bumps a little bit, but weight plateaus. It really doesn't come up, and it comes down. There's several things I want to show here. One, even though this is a graph of only one patient, when we look at our data for hundreds of patients that's gone through the detox, we see the same characteristic. Around week 3, the systolic and diastolic blood pressure goes up and then comes back down. There may be some kind of a detox phenomena that occurs at this point in time. It's not quite clear to me. We may need to measure biomarkers, but certainly we see that trend where the levels go down. So baseline triglyceride, the total cholesterol was 317. At the end of 4 weeks, it went from 317 to 189. Notice how the total cholesterol went to 189, which is lower than where the LDL cholesterol started out. The LDL cholesterol started at 226 and it went down to 126. Now, notice the HDL went down. The HDL goes down routinely, largely because you need less HDL. The total cholesterol is getting so much better, then the HDL gets better, and so it goes down significantly. Triglycerides went from 286 down to 84. Notice the inflammation. The C-reactive protein went from 1.4 down to 0.5, and the hemoglobin A1C went down from by 5%, went down from 6.3 down to 6, and that's a significant difference. We've shown in our published data that we see a significant change in hemoglobin A1C after just 4 weeks. And I'll explain that a little bit later as we go through some days. So with this one patient, we saw some amazing changes. Here's some data from our group. This one patient, the overall relative changes. So he had a negative 11% reduction in systolic blood pressure, 12.4% reduction in diastolic blood pressure, about a 6.6% reduction weight. Notice, so the hemodynamic changes a little bit better than the anthropomorphic changes. Weight, only about single digits. Hemodynamic changes, low double digits. But then you start to get to the biochemical changes, the lipids and all, about 30 to 45% reduction. And notice with the inflammation in him, about a 75% reduction in C-reactive protein. Hemoglobin A1C is about almost a 5% reduction, as I said, in hemoglobin A1C. So very significant changes in this one patient. And I can tell you that these changes and the same characteristics and the ratio changes we see when we look at groups of patients, groups of 30 or 100 patients or 200 patients, this same trend holds true. Let me go into another patient that we treated with a food prescription, a 65-year-old man with known coronary disease. He had multiple prior heart attacks, known coronary disease. His heart was weak. Ejection fraction is the percent blood that the heart pumps each beat. So normally should eject about 50% or more. His heart was only ejecting 35 to 40%. So it's decreased. So this is called congestive heart failure or weak heart. He had symptoms of chest pain, shortness of breath with mild exertion. These are his known diagnosis. So the clinical intervention, we did medication adjustments, and we also did a nutritional intervention. So he came to the office, and this is actually after he had gone to an emergency room. And so with the known disease, we put him on a nutritional detox. Now, here's some data. Now, there's some complex data here, but it's not too complex. But this troponin, TN stands for troponin. Troponin is just a molecule. It's a protein molecule, sub-molecule that comes from the heart muscle cell as part of the heart myosin contained apparatus. And so when heart muscle cells are sick and dying, they break up and they leak out some of their contents. And troponin is one of the things they leak out. And we measure the blood levels of troponin. Normally, when you go to the emergency room, any of you may have gone to the emergency room with chest pain, they check a troponin level. If that troponin level is high, they say you have a heart attack. However, in the emergency room, they check a troponin level of nanograms per ml. That's the level of accuracy they measure. Nanograms is about 1 billionth of a kilogram. Picogram is 1 trillionth of a kilogram. And so this is a much smaller and a much more sensitive measure than what they get in the emergency room. The reason I'm pointing this out is that in our office, we can measure ultra-sensitive levels of troponin. What does that mean? That tells us if the heart is under stress. So this level is high, and so we know that it's high. So we know that the heart is under stress. And so we can measure the amount of stress on the heart. If that number goes down, then the heart's under less stress. So when this patient came and saw us on this date, his heart was under a certain amount of stress. Over 10 picograms per ml is a sign that puts you at risk for having a cardiac event down the road. So we want to get this number at least below 10. So we saw him start off at 10. And then after the first week, it went down. This is on week 1 of detox, went from 28 to 5.7. And it continued to stay down below 10, except it bumped up a little bit. Now he was taking glipizide. We stopped the glipizide, and the levels went back down and stayed down below 10. And so if you look at this on a graph, so the amount of stress, the way to read this, the amount of stress on his heart, based on the troponin level, significantly reduced on the detox. And so we were able to measure that. So Flea Bite Girl wants to know, Yolanda, let's see. Grateful for all you give us, brother. Thank you. Ever go home? I'm always at home when I'm talking about medicine, Yolanda. Can a CRP test result be higher than normal due to poor dental health? The answer is yes. Any kind of inflammation can give you a high C-reactive protein. And even though we measure ultra-sensitive C-reactive protein, which is supposed to be specific for myocardial stress, I've seen and see routinely, I should say, that someone has systemic inflammation, the ultra-sensitive C-reactive protein will be elevated. So here's a little bit more diagram. Detox started. First week of detox had a significant drop. This is that magical 10. We like to keep it below. It went above that, and I think getting off the glipizide sort of kept this oscillation down, and it went down and stayed. So the detox helped out a lot. And glipizide, by the way, is a medicine for diabetes. It's a sulfonylurea, if I remember correctly. But it has a side effect of causing ischemia in patients with known heart disease. So that could be a problem there. So data analysis of the food RX, what are the hemodynamic effects? So we looked at our food prescription approach, again, using the food classification system in 15 individuals. And these patients came in and we looked at their blood pressure, waist circumference, BMI. We looked at the cardiac output, and we measured it non-invasive. So we have a device in our clinic where we can measure their hemodynamics and get in a non-invasive way, look at how well their cardiovascular system is working. So cardiac output is the amount of circulation your body's getting from your heart. And we saw that go up significantly, or it trended up. There wasn't quite statistically significant, but it trended up. We saw an increase in stroke volume. So that's the amount of fluid the heart is circulating with each contraction or each heartbeat. The resistance, the amount of stiffness in the arteries, we saw that go down in our food prescription. So they had reduction in the resistance of flow. So the blood vessels became more relaxed. The amount of volume, thoracic fluid content was the amount of volume. So the hydration level increased. We were able to measure that. And the heart rate went down. So because they were circulating more blood or ejecting more blood per heartbeat, and the blood vessels relaxed, so the heart was working less or had less stress on it, the heart rate went down, and we saw the systolic and diastolic blood pressure go down significantly. And of course, waist circumference and BMI went down significantly as well. So not only did we see, most people look at weight loss, et cetera, but we were looking at many other factors and their hemodynamics, their cardiac output. The heart was under less stress. And as a result of that, the heart was performing more efficiently. So that's an important thing. I want to just look at this real quick, anthropometric, and blood pressure trends. most people, and the point I want to make here is the following. I'm going to skip through. This is a busy slide. I'm going to put this up here so you guys can take a picture of it and just look at the details. But the next one is really on this next couple of graphs. As I showed you before with that one patient, we see this with, this is a group of about 15 to 20 patients. I have similar data with more patients. We see that the average systolic blood pressure drops at the first week. It sort of plateaus the second week, but by the third week, it goes up again, such that it's higher than after the first week, and then comes back down to where it's lower overall. You get the same thing with the diastolic pressure. Initial rapid drop, a little bit more of a drop, but then it comes back up on week 3 and then goes back down. So you see this bump, and we call this a cubic trend with 2 bends in the curve, okay? So if you look at the weight comes down initially, and it plateaus a little and comes down more. There's really only one significant bend. So it's a quadratic trend showing a single bend in the curve. So a bend, then a plateau, bend, plateau. Same with weight and BMI. Waist circumference, similar thing, bend and plateau. So we see here how the weight changes and how the blood pressure changes. And if we superimpose them, you look at the orange and the blue. The orange is the diastolic blood pressure, the blue is the systolic blood pressure, and the red is the weight. Notice how the weight comes down. So the first week, the weight and the blood pressures come down about the same. So after the first week, you say, well, the blood pressure is coming down likely because the weight's coming down. You can make that argument because if you just look at that first week, they're both coming down. So one can be secondary to the other. However, after you go from week 1 to week 2, guess what? Certainly on the systolic blood pressure starts to trend up. And definitely by week 3, both systolic and diastolic pressure is going up while the weight is still coming down. So what we can see here is that there's a divergence in how the weight changes and how the blood pressure changes, so that we know that the blood pressure changes are independent of the weight change. So even though you're losing weight, the blood pressure changes in a different manner. So we know that there's a difference in terms of what's happening. And the point I want to make here is that the biochemical and hemodynamic and physiological changes are happening independent of weight loss. And this bump here at week 3 could very well be due to a detox reaction. And it could be related to the fact that because you're cleansing things out, it may have an increase of effect on the blood pressure. I'm not going to bore you with too many of these slides, but again, cardiac output, it's improved. That's a good thing. Stroke volume, it improves the amount of fluid that's circulating. The relaxation in the blood vessels, that improves. The heart rate goes down. That's good. Your heart's working more efficiently. And your volume status, that's thoracic fluid content. The volume status go up. That means you're more hydrated. So these are the changes we see. In summary, these are hemodynamic. The heart gets stronger, okay, and more efficient. Okay, strong and more efficient. Stroke volume, all of these things improve, and they are significantly improved. So you get an increased stroke volume, increased cardiac output, increased hydration of volume status, and a decrease in vascular resistance. So the blood vessels are more relaxed. And notice how that is about almost 27% compared to systolic and diastolic blood pressure. So these blood pressure changes are likely due to the fact that the blood vessels are relaxing more. That's what that tells you. And then weight and BMI, these things are changing. Notice how much these things are changing to a smaller amount compared to the major hemodynamic changes you're getting. So again, we often look at weight loss when we're looking at a diet, but if you're on a truly healthy nutritional regimen, and let's say you're losing, 3% of your weight, your hemodynamics are improving almost tenfold. So whatever amount of weight loss or weight change, then you're improving. Sonia wants to know, what is a normal heart rate? The normal heart rate generically is between 60 and 100. However, I think it's ideal for the heart rate to be at least less than 80, preferably between, say, 60 and 75 is a preferable heart rate for me. People who are conditioned may have heart rates that are lower. Some trained athletes may have resting heart rates in the 40s. So normal really varies depending on your circumstances and your physiology. But the the technical normal, statistical normal is 60 to 100 beats per minute, is what you'll see. We also tested this in individuals that we had MRIs of the heart on before and after. And so with an MRI of the heart, we can see not only how well the heart functions, but we can see the size of the heart. So there was a case series of patients, there were 3, in fact, and we actually published this case series where we looked at their heart size and function before and after nutritional intervention. They each had a very low ejection fraction. Remember, I told you the ejection fraction is the percent of blood that the heart pumps with each beat. It needs to be greater than 50%. Theirs was 22%. It had been established that way for over a long period of time. And so they had New York Heart 2 and 3. That means they had some symptoms with each mild to moderate exercise. And they were all on the standard heart failure treatment regimen. So we got MRIs at baseline and an average of 78 days later. And what did we find? Well, similar to when we measured the hemodynamic, made the hemodynamic measures non-invasively in our office, we also saw an increase in ejection fraction. We saw an increase in cardiac output, an increase in stroke volume. But what we saw this time was that the heart got smaller. So if you notice, many people I don't know, some of you online may have been told you had an enlarged heart. An enlarged heart can be due to the fact that the heart is dilated because it's congested with excess fluid, or it can be thickened because it's working against a lot of increased blood pressure. So the mass or thickness of the heart, we saw it went down. The volume, end-diastolic volume, and systolic volume also went down. So the dilation of the heart was reduced. So basically, we think these are promising results, and we're going to do more work. Here are the graphs to kind of show you pictorially in the graphs. So the ejection fraction on average went from 22% to 42%, which is important. LV mass went down significantly from 214 grams to 170, which is very good. And the volume went down. So in essence, the heart got stronger, as was indicated on the bars on the left, and it got smaller, which is indicated on the bars on the right. Decrease LV mass, decrease in systolic and diastolic volumes. In other words, decrease in the dilation of the heart. So we see that in patients when we apply the food prescription approach in the appropriate manner. Here's one case, and this is one of the patients that was in the earlier case presentation, a 46-year-old lady who came to see us, and she really initially wanted to lose weight. So she had gone to a health fair at her job, and she, was overweight, and she had some pre-diabetes diagnosis, and her blood pressure was a little high. So she felt if she just lost weight, everything would correct itself. And so she initially sought the care from a gastric bypass surgeon. They did a screening EKG and saw that it was abnormal. They said that we probably should get a clearance from a cardiologist first. And so that's how she got to us. When I saw her, we saw that she was having chest discomfort that woke her from sleep, was a little bit concerning to me, shortness of breath with exertion and some fatigue. So we did an EKG and it was actually abnormal. The echocardiogram that we did in our office showed that ejection fraction was 20 to 25%. And we did a cardiac MRI and it was 24% on MRI. So based on these findings, I took it to the cath lab because I said, look, we need to do more testing. And so I did a coronary angiogram. This is my catheter here. And the dark part is where we inject the dye. So really it's like taking an x-ray of the chest with a catheter in your heart and us injecting dye. And so this is the left main coronary artery. This artery here, we call it the LAD. And this is the circumflex. So the names are not that important, but notice this goes in the front of the heart and it's a very important artery. Notice this little pinched in area here. It's in this yellow circle, so it must be important. There's a critical narrowing there. This pinched in area that's critically narrow represents about a 90 to 95% stenosis or narrowing or blockage, if you will, in the proximal part of the LAD. They refer to this as a widowmaker because if this shuts down, you lose 75% of the blood flow to the heart and you can potentially die suddenly. So in this case, it's a potential widower maker. So we saw this and this is too dangerous. It'd be too dangerous to try to put a stent here because plaque can go back into the left main and we cause a lot of problems. So we recommended to her, after the procedure, we came out, and after she recovered from this procedure, I talked to her and her family and said, well, the best option here would be a single vessel bypass because this is not a lesion that's amenable to a stent, especially where it is, and it's probably plaque right here. So she had initially heard about a detox program because she was at the office and we had talked about it, and she wanted to try that first. This was her decision. So we didn't really force her down that realm, but she said, look, I want to hold off on the procedure and I want to try the nutritional thing first. So we put on the detox food level from 0 to 4B. And after 5.5 months, she went from this 95% stenosis to this artery being wide open. And so Sonia wants to know if it's okay to exercise with an enlarged heart. Well, Sonia, it depends. There are a lot of people we have with heart failure that have enlarged hearts. And based on the fact that we've got them on a clinical observation, they're clinically stable, then yes, they can exercise. So it just depends on what your doctor recommends and what your condition is. So until the 4B detox, this artery also got better. The stenosis went away. The other arteries got better. So she had improved function in her heart. And that's right, Catherine, a picture is worth 1,000 words in terms of what we're seeing here. We can see how the body can heal itself in the setting of optimal nutrition. She did not require a stent or bypass surgery. In optimal nutrition, her heart got stronger, arteries opened up, and things improved significantly. So here's some of our data. We published a lot of this in the medical literature. We show where plant-based diet utilized in an outpatient cardiovascular clinic can be effective in treating hypercholesterolemia, hypertension, and reduce medication. So if you remember from that first page, we had the A, B, and C option at a very high cholesterol. We said, well, what should we do first? Well, we decided to treat him with a defined plant-based diet because we know based on our evidence, this is scientifically validated, that we can start the nutritional regimen before starting the medications. And we've shown it, and the evidence shows that it's very effective. Not only is it very effective, but we can do it while reducing medications in individuals who are already on medication. So, is it okay to have balsamic vinegar dressing on my salad? Yes. Make sure it's a good quality balsamic vinegar dressing. So here's some of the profiles of the patient we saw. More females than men. The average age is about 53. They had a high BMI. And they were about a third of them had coronary artery disease, and almost a third had type 2 diabetes and arthritis. So they had a fair amount of comorbidities. Now this slide is busy. I apologize. This is the food classification system in detail. I'm going to leave that up here and let you, hold on one second. Let me do this. This is not usually what I do let's see, hide. I'm going to change my screen here. One second. I apologize. I want y'all to be able to see a little bit of the details of the food classification system. So I'm going to make a few changes here. I don't normally do this. Let y'all see how ugly my screen is. But let me just get this to where y'all can see a bit more. Give me 1 minute here. Okay, so I hope that's much better. So there's a lot of business on this slide. What I want you to do, obviously you can screenshot it on your computer or whatever, but this gives some details of the food classification system. It's in that publication and it shows you there. I'm not going to play with this too much. You can do a screen share and magnify it, but what it is, it shows the foods that they ate and how it changed. Their number of plant foods went up by anywhere from 300% to 800%. Interestingly enough, somebody asked about avocados earlier, and I forgot who asked about avocados, but the number of avocados they went up by 9-fold from 0.1 to 0.9. And despite there's an 800% increase in avocados, their cholesterol went down, their weight went down, and so on. So, they did quite well. Hemoglobin A1C went from 5.9 to 5.7, a significant drop. Remember, we saw it drop in that individual. And this is in a group of 31 patients, a significant drop, reached statistical significance. So why would a hemoglobin A1C drop in a month? Many of you may know the hemoglobin A1C represents the average blood sugar over 3 months. So why can we show a change in 1 month on a 3-month average? I can tell you the reason is because hemoglobin A1C is also affected by the blood sugars, fluctuations in blood sugars. So if you're having wide blood sugar swings, then your hemoglobin A1C will be increased, and so it can have an effect. And so what we probably did here is decrease the fluctuations in blood sugar, and therefore we saw a reduction in hemoglobin A1C that was very significant. C-reactive protein was reduced significantly by about 30%. We saw that again only in about 4 weeks. And so we see very significant changes in, and also there was about a 40% medication reduction here. This shows blood pressure changes, similar kind of bump at week 3 that we see before. Total cholesterol went down, LDL cholesterol went down. Here's the number of medications they were on, okay? Baseline, on average, they were taking about a little over 2.5 medications each. It kind of stayed the same, maybe went up a little bit. But by week 2, it went down to 2.3. By week 3, 1.8. And by week 4, it went down to 1.6. So they reduced by, on average, a full medication per patient in a matter of just 4 weeks. And we see in other individuals how this reduction can be even more. We're getting close to the end. I know it's a little bit long. We're almost there. The consumption of plant-based diet on other parameters. We looked at other biomarkers. I showed you this with other patients. Cholesterol goes down. LP(a) went down by 16%. That's an atherogenic molecule that we know could predispose or cause heart attacks, even if you have a normal cholesterol level. Here's a busy slide. I'm not going to go through all of this, but this shows you the details of all the cholesterol levels going down, as well as LP(a) going down by 16%. Very important. C-reactive protein, we see cytokines. IL-6 is a cytokine that went down significantly. We know about cytokine storms, talking about coronavirus infection. So cytokines can go down on a detox regimen of plant-based diet. Overview biomarkers. I'm not going to belabor this. We know that weight and anthropometric measures go down by a small amount. Biochemical measures, cholesterol even more. And then inflammation, CRP, and set rate go down very much. The BUN is a blood urea nitrogen. That's always going to go down on the plant-based diet, because when you consume animal proteins, the nitrous molecules from the animal protein is converted to urea by the liver. It's actually converted to ammonia, then from ammonia to urea by the liver. So your blood urea nitrogen is high if you're eating animal protein, and we remove that, then that number goes down. And so there you have it. So there you have it. We have the food classification system and its clinical application. And I hope it was helpful in what I gave you. I may have overdone it a little bit with the case scenarios and what have you, but I really wanted to get into the heart of that and give you the details. We didn't take a break this time because I wanted to go through all of that and grind through it. So I hope you got a lot of this information. I hope it was very helpful in understanding the precision of food and how it makes a difference and how we use it in an application format. And as always, if you like this information, please subscribe, hit the notification button so you can get notifications on other shows. And of course, share this with loved ones, because I think this is important information to get out to everyone. So I'd like to say thank you all for joining us tonight. We had a long Wednesday night. And until next time, detox, keep it clean. And of course, join us next Monday for Fresh Natural Live. We're going to continue our topics on supplements in the context of a natural therapeutic approach to chronic illness. We're going to be talking about heart failure, and I'll talk to you about how I use supplements and a lifestyle intervention to treat patients with heart disease. Have a good night.